students, we are discussing pneumothorax, and we have discussed the etiology, the pathology, the classification, clinical features, signs, and differential diagnosis of pneumothorax. Today we can discuss the management of pneumothorax. In management, pneumothorax is managed in three different ways. First of all, aspiration of pneumothorax, then intubation or intercostal tube drainage, and finally surgical management. Then we can go into the details. In mild cases, air is usually absorbed within a few days. It happens in case of closed pneumothorax. The volume of air is very less and naturally gets reabsorbed in a few days. But other modes of management may be needed in case of open pneumothorax or in case of closed pneumothorax. And if there is pain, they will give analgesic, and we can try our medicines for pain relief. And in case of aspiration, and if the pneumothorax is large or embarrassing to the patient, we can resort aspiration of air. And for this, a cannula is used, IV cannula is used, and the gauge is 16 gauge IV cannula is attached, and this cannula is attached to a 50 ml syringe, and a 3-way tap is attached to this 50 ml syringe. So the air is aspirated using a 16 gauge IV cannula, and this cannula is attached to a 50 ml syringe with the 3-way tap. And an intercostal space is selected from the chest radiograph. So it depends upon the area of air collection, or where the collection of area is more, and depending upon this, an intercostal space is selected. And after selection of an intercostal space, that particular area is sterilized and anesthetized with lignocaine, and is anesthetized up to the parietal pleura. And the cannula is inserted through the intercostal space, and pneumothorax is aspirated into the syringe, and it is expelled via the 3-way tap. And one end of the tube, and the tube is connected to this 3-way tap, and one end of the tube is put in an underwater seal, or air cannot re-enter from outside into the pleural cavity. So the end of the tube is connected to an underwater seal. And after doing this, if there is absence of re-expansion, if there is no re-expansion after all this process, it will suggest is pointing towards a bronchopleural fistula, and an intercostal tube drainage should be resorted into. And these are the process happening in case of aspiration. In case of aspiration using a cannula and syringe with 3-way tap. Then in case of the second mode is intercostal tube drainage. If the lung is not capable of re-expansion after choosing aspiration, they will opt for intercostal tube drainage. Then what are the indications of tube drainage? First of all, complete pneumothorax, then second pneumothorax, etc. All these conditions, they will resort to intercostal tube drainage. And the site usually selected is second intercostal space. In case of intercostal drainage, the site usually selected is second intercostal space in the mid-clavicular line, or can the sixth space also in the mid-axillary line. It can be in the mid-axillary, second space in the mid-clavicular line, or sixth space, intercostal space in the mid-axillary line. And for apical drain, the patient must lie flat, and for a basal drain, the patient may be slightly rotated towards the opposite side, lying slightly rotated towards the opposite side with arm slightly raised. Arm should be raised slightly. Then local anesthesia is given using lignocaine. Then needle aspiration is done at the site of insertion to confirm the presence of fluid. Then after that, a stab wound is made in the skin and subcutaneous tissues, and through this opening, a large cannula is introduced, or they will introduce a trocar and cannula through this opening into the pleural space. After insertion of intercostal tube, this should be clamped immediately to avoid air entering into the pleural space again. Then a suture, a purse string suture is made around the site of insertion to fix this tube. Then after that, the tube is connected to an underwater seal bottle. Then the clamp is gradually removed and the tape is taped to the chest wall. And this is the procedure in intercostal tube drainage. And few things are very important, that is care of the drain. Then removal of, when we remove the tube, X-rays should be taken to assess the amount of air in the pleural cavity. Then in case of tubal drainage also, there is failure of expansion, that is failure of expansion even after 7 days. And this will indicate into the third sort of management, that is surgical management. So initially they resort to aspiration using a syringe, then secondly the intercostal tube drainage, and finally surgical management, that is after 7 days if the lung is incapable of re-expansion. The indication of surgical management or surgical treatment is bilateral pneumothorax, then hemopneumothorax, then bronchopleural fistula, then recurrent pneumothorax, then occupational, in certain occupational risk like in pilots, seamen, in all this occupation there is variation of atmospheric pressure. So in these occupations, or the person of pilots or seamen care are having pneumothorax, they will resort to surgical treatment. The process they do is surgical closure of bronchopleural fistula, then thoracoscopy and cauterization can be done if there is a breach in pleura. Then excision of bulla can be done, and oversewing the defect if any. Then there is a procedure called pleurectomy, then bullectomy, and partial apical pleurectomy also. Then another procedure is decortication. Decortication means stripping of fibrin from the affected visceral pleura. There can be, if there is inflammation, there can be settling of fibrin over the pleural surface, and the removal of this fibrin is called a decortication. Decortication is a surgical procedure. Then, as a last resort, surgical resection can be done. That is the removal of a part of lung. That is surgical resection. So these are the surgical procedures. Closure of fistula, thoracoscopy, cauterization, pleurectomy, bullectomy, partial apical pleurectomy, decortication, and finally surgical resection. So, in case of management of when coming into the management of pneumothorax, 3 steps of management are there. That is normal. First of all, normal closure without any intervention. And when we intervene, it could be aspiration using a syringe, then intercostal tubal drainage, and finally surgical management. That's all about the management of pneumothorax. Thank you.